Community Mental Health in partnership with the Community Services Coordinating Body. Today's presentation is titled When Epics Collide, the Impact of COVID-19 on Opioid Use Disorder. This presentation is being recorded. My name is Deb Johnson. I'm the Executive Director of St. Clair County Community Mental Health. And before we get started today, I wanted to introduce our esteemed speaker, Dr. Frank McGeorge, but I have more to say about him in a minute. Before we get started, I want to share a few tips about housekeeping and to ensure an engaging and interaction session today. First, we want to encourage you to enter any questions and comments you have at any time throughout this webinar using the chat feature found at the bottom of your screen. We will do our best to answer as many questions as possible at the end of the presentation. We hope this chat box will serve to as an interactive space to share different strategies, ideas, and resources related to our topic today. This webinar series is made possible by a grant award from SAMHSA, which is the Substance Abuse and Mental Health Services Administration. We are very excited to provide this virtual series during the month of September, which is also National Recovery Month. Continuing education credits are offered today for social workers, substance use treatment providers, physicians, nurse practitioners, registered nurses, physician assistants, and EMS personnel. If you are interested in receiving these, please make sure that when you signed into this series, you used your full first and last name. If you need to change the way you entered your name, you will need to log out of the webinar, click on the webinar link again, and you will be prompted to enter your name and email. You must be logged on for the entire duration of this presentation. Participants who are not logged on for the entire duration will not qualify for continuing ed credits. CE credits will only be provided to those who complete a short quiz and a survey after this webinar. These materials were included in your registration and must be completed within 7 days. This series will have an in and an out code that participants will need in order to complete the quiz. Today's in code is all caps keynote, K-E-Y-N-O-T-E, keynote. So now we are joined today by Dr. Frank McGeorge, emergency medicine specialist at Henry Ford Health System and medical correspondent for WDIV Channel 4 News. In addition to helping Metro Detroiters with health concerns as a doctor on television, Dr. McGeorge is helping save lives every day in the emergency room at Henry Ford Hospital. So with that, I'll turn it over to Dr. McGeorge to get started. Welcome.
Thank you so much. So, I welcome everyone to this very unusual forum. The only upside to this in my mind is that there was a little shorter drive time. The technology thing is still a little bit of a mystery. So I want to start out, I guess, by pointing out that I agreed to speak live here, if you will, at the beginning of the year before COVID was even a thing, and frankly, before the title of this talk, When Epidemics Collide, the Impact of COVID-19 on the Opioid Crisis, would have even made any sense. So my real job, of course, as you know now, is that I am an emergency physician who has worked primarily midnight shifts the majority of my professional career. So I've frankly seen more than my share of the effect of addictions, whether it's alcohol, opioids, or any other drugs in the emergency department. Now, my other role, of course, is as the medical reporter for WDIV, that's Channel 4 News in Detroit, where I've reported on the opioid crisis from a number of different, lenses. Now, I was originally asked to talk about my experience in the ER, ways that I've seen to combat the epidemic. And honestly, I can still talk about those things. And if you're interested in my perspective on that, please ask questions. But until some questions pile up later on, I'm going to talk about the title of this talk, and that is something that's devoured my life completely and probably something that's devoured most of your lives, and that is COVID-19. And so the real question here is, what happens when a pandemic and an epidemic collide? Well, with limited resources, the epidemic, in this case, it's the opioid epidemic, will find itself in the back seat. Now, I'm sure you all remember back when the rapid awareness that was brought to the opioid epidemic facing the U.S. was just on a crazy ramp up. That's all we were talking about. For a while, it was occupying the 24/7 news cycle on a constant basis. For opioids, we were reporting new statistics every single day. Well, now with COVID-19, you would hardly know that it was still a problem. But it's not really just a problem. It is, in fact, a growing problem, and it's become more deadly. So here's a statistic, and I'm going to be throwing out a lot of these numbers, but pay attention to the differences, I think. So the first 4 months of this year, 2020, there was an 11% increase in deaths compared to 2019 from opioids in particular. So deaths are definitely up. The epidemic of opioid abuse is definitely on the rise, and it's definitely a significant piece of the COVID problem. Now, prior to this pandemic, we were in the midst of an opioid addiction crisis. That was an important crisis that warranted governmental, medical, personal, and frankly, media attention. Well, now with COVID-19, it's been completely overshadowed by the disease headline. But just like we've talked about the hidden excess deaths from heart attacks, strokes, untreated cancers, or other ailments among the added burden of COVID. So with COVID, people weren't going to the hospitals, they're not going to emergency rooms, there were more heart attacks, et cetera. Well, excess opioid deaths and addictions, as well as the destroyed lives, those should be counted in COVID statistics as well. They're not currently, and that's just something that I think is food for thought for public health. Anyway, I work at Henry Ford Hospital in downtown Detroit. I have been witness to the opioid epidemic since the start of my career 30 years ago, and that's how long I've been practicing. I'll tell you a quick story from my first year at Henry Ford in 1990. So when we're sewing up lacerations, cuts on people, we have a lot of time where we're just basically talking to them. And there was this gentleman that I was sewing up. This was in 1990 when I was a new doctor, sewing up a laceration on his arm. And I happened to notice that he had track marks all up and down his arm at the time. And I was a new physician. I was from Chicago at the time. I had been new to Detroit, which frankly, I will be honest, back in 1990, my perception of Detroit was that this was like some, die hard, I guess more aggressive drug using city than Chicago. I've come to learn that actually Chicago and Detroit are really not that different from a drug use perspective. But the thing was, I asked the guy, so you've got all these track marks on your arm. I gather you use heroin. Didn't heroin go out in the 70s? Like that was my perspective in the 90s. And he just looked at me and he said, man, heroin has not gone anywhere. It's just getting bigger and it's never going anywhere. And sad to say, he was absolutely right. This was a conversation 1990, 30 years ago. And unfortunately, it was prophetic because it is something that we are not seeing go away. So go forward a few more years. I was actually at Beaumont Hospital for 10 years in Royal Oak. Turns out Royal Oak and other suburbs, they were also never immune to opioids. Back then, it was just a quieter epidemic that was just slowly infiltrating every corner of America. Again, that was more than 10 years ago from today. Actually, it was about 13, 15 years ago. Now, think back 13 or 15 years ago. Frankly, back then, doctors were being encouraged to treat pain. That was our mandate. Everyone was being asked to rate their pain. And if doctors weren't controlling pain aggressively, we were frankly made to feel like we had not taken good care of our patients. No surprise then that most well-intentioned doctors, dentists, and other medical professionals, well, we ended up unwitting accomplices to this widening epidemic. We were handing out prescriptions feeding the epidemic at the time, and we did not know how bad it was becoming. Now, fortunately, of course, there was finally attention focused on it. Laws regarding the prescription of opioids, they've changed, and that has had an effect on at least the prescription supply. But as you well know, there are still legal opioids that are being diverted. There are still ways that people are, if you will, cheating the system. And certainly the illegal drug trade has adapted. Now, those are some things that I can talk about later if you have further questions. But fast forward now to 2020. Okay, so we're present time, COVID, stay-at-home orders, sweeping changes to our way of life. They have put people out of work. They've isolated people from their social groups. And frankly, I think they've stressed everyone out. I know I'm stressed out with this just bizarre, seemingly unending circumstance of uncertainty. So is it really any wonder that substance use disorders are on the rise? It's not only prior addicts that are relapsing, I want to emphasize. It is new users. People are turning to drugs because this is a very bizarre circumstance. Now, I hesitate to use the phrase an unprecedented event because when I refer to because I think it's just overused in my opinion. But this COVID thing is definitely something new. And people had to adapt, and people of substance users specifically have had to find new ways of tolerating and working through their substance use disorders. Now, in the very beginning, actually, it was a little bit of a paradox when you look at the statistics. Many substance users, in fact, tolerated lockdown better than expected, largely because they were also kept away from many of the triggering social circumstances that might cause a relapse for their particular addiction. I mean, everyone thought that there was going to be a very limited stay at home. People kind of got used to things, and people siloed themselves and had sort of a new way of dealing with things. But of course, as you well know, the situation, it just dragged on and on and on. And as days turned into weeks and turned into months, in time, the stress just increased. And ultimately, anxiety, depression, cravings, it became more than anyone expected. Border closings, for example, have disrupted illegal drug trafficking, which you would think would be a good thing, but it's meant more home-brewed synthetics and some production inconsistencies with new sources of the drugs. And of course, with new dealers came new drugs with new quality control issues, meaning they were being cut differently. There were synthetics that we had not expected and people came in basically saying, coming to the emergency department, basically saying now that they have a new source. They're not really sure what happened. And so these new production inconsistencies, quality control issues have become an issue with regard to the epidemic. Now, the statistics are really clear as far as substance use disorders. Alcohol sales, for example, they are up 25% since the beginning of quarantine. The quarantini, that is a thing. Alcohol to go, that is a thing. It didn't used to be a thing. A recent study of 500,000 drug tests found, so this was 500,000 drug tests sent into a commercial lab, found between March and May, so from the time of lockdown to May roughly, there's been a 32% increase in non-prescribed fentanyl. So fentanyl use on the rise like crazy, a 20% increase in methamphetamines, and a 10% increase in cocaine. And of course, this is all translating into real world consequences. First responders right here in Macomb County, they recently reported a 23% increase in Narcan use by EMTs that were responding to overdose calls between May and July of this year compared to last year. So Narcan use is up largely because they're saving lives with it in the field. Overall, EMS responses for opioid overdoses increased 33% across Michigan between April and May of a 2-month span. Overdoses increased 33%. Again, obvious signs that the opioid crisis and the pandemic are merging into a much more serious situation. Also, comparing this year to last year, overdose call volumes are up by 26% between April and June. So if anybody has any question of whether COVID-19 has worsened the opioid epidemic, I think the evidence is really pretty compelling. And just like stay-at-home orders weren't just a Michigan thing, these trends aren't either. This is happening around the country. In fact, a research group from the University of Baltimore, they looked at patterns of drug overdoses since the implementation of stay-at-home orders in every state. So this research group, every state they looked at, they found across all states, there was an 18% increase in suspected overdoses comparing the weeks prior to after stay-at-home orders. And then on top of that, comparing 30-day rolling averages from March through May, there was a 7% increase in the actual number of overdoses in 2020 compared to 2019. So this is a Michigan problem, but is a national problem. And I think that's something that has been lost as we've tried to focus things on COVID-19. There is another undercurrent epidemic still running. So just because we, the media, aren't shouting about this from the tops of buildings anymore because there's a global pandemic going on, doesn't mean that it isn't continuing to exact a severe toll on our communities and our loved ones. This is something that everyone needs to pay attention to, and I'm frankly hoping that either the pandemic moves on eventually, I'm not sure how long that's going to take, or we begin to focus some more resources on what I think is a much more serious community problem than has really been reported on or than we've talked about in the past. Now, I should also mention from a medical standpoint, it's not only opiates that are a problem. Year over year, we've consistently seen new synthetic drugs become more widely distributed. And unlike opiates, there's no antidote to these synthetics. So this is something that I see in the emergency department all the time. I've spent many nights with people on ventilators, overdosed on who knows what, that are going to frankly just be unconscious for who knows how long. And those are the lucky ones that make it to the ER alive. A lot of people don't even make it to the ER on some of these new synthetic drugs. Now, sometimes, again, it's what it's being cut with, but sometimes these synthetics just went wrong, bad recipe, whatever. And that's been an issue. Now, this all sounds pretty bad, I realize. Increasing numbers, a worsening epidemic, new synthetics on the market, changes in supply lines and quality control. This all sounds bad, especially when there is no clear end in sight to COVID-19. So the question is, what can we really do about the situation? I mean, I think that's what we're in search of our answers. Well, right now in the time of COVID, we have some limitations. Clearly, in-person solutions, and I think this group chat where my video randomly drops out is a highlight that we need in-person solutions, because these kinds of situations are very artificial and odd. But clearly, in-person solutions like group sessions, one-on-one therapy, even inpatient treatment, they're all obviously limited because of infection control restrictions. Now, one interesting thing, though, of course, that has been a solution that has grown exponentially since the start of the pandemic is telemedicine. And whether it's Zoom or whatever app your teledoctor is using, restrictions on the use of telemedicine, and more importantly, insurance coverage actually, have been changed much more accessible. In fact, a study from the University of Michigan that was published in July noted that remote medicine, telemedicine, was actually lowering barriers to care, in particular for addiction care, especially because more remote or rural areas could now be better served. And so I think what this has uncovered is a niche that can actually help the overall broader epidemic. Now, the concern, though, that the authors from the University of Michigan voiced, though, was whether or not this telemedicine breakthrough, if you will, was last. Would these barriers to and barriers to remote care especially remain low even after the pandemic? And unfortunately, we just don't know the answer to that yet. But I think just like we're learning to adapt to Zoom and we're learning to adapt to, it looks like it was kicked out again. I can't quite tell. I don't know. I think I'm just going to keep going. In either case, just as we continue to adapt to Zoom calls, there are other improvements to delivering care, like changing the rules that allow physicians. Okay, looks like people can see me. Okay, thank you. I appreciate that. So just like adaptations to Zoom and whatnot are improving our delivery of care, there are other changes in the rules that the pandemic has brought that have really also helped. For example, physicians we use buprenorphine as an addiction recovery aid. Well, now the rules that control the prescription of buprenorphine or other controlled addiction treatment medications to patients have been loosened, and now we can prescribe it through visits, and that has made a big difference. The shift to the virtual world has been very interesting, I think, and it's something that we all need to take into account. It's moved it at, frankly, I think, I don't know how many of you had ever even heard of Zoom before the pandemic. I know I had never heard of it. But Zoom and other telemedicine platforms have moved at a blinding pace, so much faster than the way changes usually occur in medicine, which really means we still have a lot of unanswered questions. I mean, are virtual sessions really effective? What's the compliance with virtual sessions? I think, in this case, for example, I'm speaking to all of you. I can look down. I see there's a little bitty chat box here. While I'm talking, I'm trying to make eye contact with you, but I can't. It's hard to read the chats while I'm making eye contact, etc. I cannot see any of your nonverbal cues. So normally, if I was speaking to you in an audience, I would see you nodding. I might see you falling asleep. I might see some people, agreeing, disagreeing, whatever. You get that feedback. I have none of that right now. I am speaking into the ether. So and imagine if you had a doctor's visit and your doctor was not able to, or you had a group visit, I should say, and people in the group could not communicate in the way that they normally do. Nonverbal cues. You can't see whether I'm shifting my feet. You can't see what else might be going on beside me. Those nonverbal cues that we use to evaluate how well a person is doing, it just gets lost in this weird virtual artificial world. And of course, certainly with limits to in-person monitoring. So remember, part of it is you want to see the person that you're treating, but part of it is in-person monitoring of drug compliance is really important. Drug screening for compliance, that's all important. Well, we now have limits on all of that, which means that every treater is flying a little blind, basically. I am really hopeful, though, that in time we're going to develop or figure out best practices. And maybe when the in-person world resumes, we can figure out some hybrid of telemedicine and in-person evaluation that works better for everyone. But until that hybrid solution comes up, we're just going to be flying blind. We're going to be trying to figure out what solution might work best, because this is really a brave new complicated world. And I'm not really sure how we're going to face all of the challenges. I guess I'm going to end my COVID comments there. But before I ask for questions, I want to touch on some things that were actually part of my original talk on perspectives, the epidemic from an ER doc. So I guess first, the good news is that Narcan use is up. We talked about that earlier, and without a doubt, it has saved lives. But of course, the bad news is that pre-hospital Narcan use is up, and that means that more people need it. And what I've seen in more recent years, along the lines of the Narcan phenomenon, are an increasing number of substance users that are coming in with apnea, as they're not breathing, mental status changes, confusion, et cetera, that are either minimally or non-responsive to Narcan. And that is, I think, primarily because new synthetic drugs, new combinations of drugs, the inconsistent content I talked about, they're all making them much more dangerous. So it is just not uncommon anymore to have to put someone on a ventilator to protect their airway and support them for 12, 24 hours even, just waiting for whatever they took to wear off. So while Narcan is a wonderful thing that has changed the dynamic of pre-hospital care, life-saving in opioid epidemics, I think unfortunately we are seeing new drugs that are coming out that are essentially taking away some of the benefit to Narcan. Unfortunately. I mean, that's just my observation from the emergency department. I guess lastly, I'll close with this, what I think is a little bit of an interesting tidbit. There was a brand new study that found the 3 top most used drugs during COVID-19, and this was a survey, but the top 3 drugs being used during COVID are actually marijuana, alcohol, and hallucinogens. And that's interesting because fortunately, none of those tend to be as life-threatening as opioids. Doesn't mean the opioid epidemic has gone anywhere, but people are obviously turning to different, somewhat easier to get things that, as you might imagine, provide a larger degree of escapism. And with that, I guess I'll stop and see if there are any questions. I'm not sure how you want to do this, if you want to ask or if I should just read things. I don't know if a host or moderator wants to come online and tell me.
Hi, Dr. McGeorge. I'm the moderator. And so I have some questions for you that came through in the chat and some that have come through on our Facebook live feed. So someone questioned first, synthetic drugs such as, could you describe what those are just for everyone?
Yeah, so the interesting thing is we actually get regular reports from the DEA and from other agencies about some of the synthetic drugs. There are actually a wide variety of them that are not specific, and that's part of the problem, actually. So, you've undoubtedly heard about the increase in marijuana equivalents that people tried to create synthetically. That's some of what we've seen, but unfortunately, a lot of these synthetic drugs, they have unusual or kind of, I guess, the trade names, if you will, street names that people are using to try them. But a lot of these synthetics are poorly classified. Some opioids, some of them are hallucinogens, are methamphetamine equivalents. Some of them are marijuana equivalents or cannabinoid equivalents. But these synthetic drugs actually, they cover a wide scope. Fortunately, the problem is because a lot of the people who are using them don't know what they're using and they come in unresponsive. There never is a good answer or an antidote to what to give people. And that's been kind of a problem for us. So I guess that's the answer to, we don't have a good handle on what a lot of these synthetics are, quite frankly.
Okay, another question that was asked, is there health disparities for African Americans as it relates to substance use and COVID?
Sure. Well, it has to do with access, as always. And I think, I think in some ways it may have decreased some of the access issues because now there's better telemedicine. But of course, lower income, impoverished areas have less access to things like telemedicine, iPads, phones, laptops, whatever. And that means that there is less access to even telemedicine. So until we see those barriers drop, yes, lower socioeconomic groups, neglected groups, African-American populations, any population that is not a focus of this issue is going to see a disparity. So I guess the answer is yes. But, to be specific, I think it really has a lot to do with socioeconomic status. So it's not necessarily relative to the opioid epidemic in COVID. I don't know that it's necessarily a race thing as much as it is a socioeconomic things. People that have transportation difficulties have always had difficulty getting care. People in more rural areas that are further away from their physician or treaters are always going to have more difficulty getting care. And just like those, people who have less access to computers will have more difficulty getting care. And those are all barriers that we need to see come down in general. But race plays a part, yes, but I think socioeconomic status plays a bigger part in many cases. And they can be equivalent depending on the region of the country, region of the state, city, whatever that you're particularly focused on.
So another question we have is, what can primary care doctors do to help support folks that are struggling with substance use during this COVID time?
Yeah, that's a really hard question because I'm in the emergency department, of course, and the emergency department is a far less than ideal place to treat substance abuse. Generally speaking, when we see people, as much as my colleagues have instituted new methods, for example, for us to be able to prescribe even Suboxone in the emergency department, we are not the ideal circumstance. Primary care providers, they unfortunately have the problem right now of trying to get office practices started up again. So in-person visits are still a problem for primary care providers. Things that they can do to help support, I think it really has more to do with access. So, fortunately, the insurance restrictions to telemedicine have been altered. So increasing access via telemedicine or any route can be helpful. But beyond access, primary care providers need to refer. I think all of us have our specialties. We have areas that we're really good at. And addiction medicine is a specialty, and addiction medicine providers do know more about addiction medicine than I do. My perspective is from the emergency department. So I think, having a lower threshold for referral to addiction medicine specialists is also another important part. But it's a difficult challenge, I think, for primary care providers right now, especially because they cannot see people in person. But going through the same questionnaires and making sure that you're identifying the problem if it's there is always going to be a critical component.
Okay. Did you experience a supply shortage such or as it relates to the pandemic, an increase in opiate overdoses, such as limited amount of ventilators and things like that? And how did that affect your role as a physician?
Yeah, so actually that's an important point because, of course, during the peak of COVID, I should say, for at least for Michigan, we're talking April, May-ish, we were admitting a huge number of patients with COVID-19 to the intensive care unit on ventilators. And so the question is, what might happen to people with substance use disorders that require a ventilator? And we didn't really see quite as many substance use disorders. So the phenomenon that was very clear to us at the time was the number of people that came into the emergency department with COVID was on a crazy increase. The number of people that came in with pretty much anything else was way down. Unfortunately, what we think might have happened was, as I alluded to before, people with heart attacks, they were dying at home. I suspect people with opioid overdoses were also dying at home. So we did not see a crazy increase in the number of people that were being intubated, placed on ventilators during the peaks of COVID. Now that we're seeing an increase in emergency department volumes and a lower threshold to call EMS, for example, we are seeing more and more people with serious substance use disorders coming into the emergency department than we did during the peak. But again, I suspect during the peak for us, again, in Michigan, April, May, a lot of those opioid overdoses probably died at home, sadly. People were reluctant back then to call EMS, to call anybody. They just wanted to hide out at home because, frankly, they were scared to come to the emergency department or scared of COVID, and sadly more scared than their need for help, which sort of brings to the initial point as well. That might be why some of the statistics that substance use disorder patients may have coped better in the very beginning of the pandemic. That's been hypothesized, but there's really no good way to prove that other than we saw fewer of them. But maybe we saw fewer of them because they were just afraid to come seek care, frankly.
Gotcha. Kind of going back to the treatment end of things, one of the questions from the chat was, can any physician prescribe Suboxone type drugs, or does it still require a special certification?
Yeah, it does. It actually still requires a specific waiver. So the simple answer is no, not every physician can prescribe it. So primary care physicians, they have to go through a special training course. Emergency physicians actually have to go through a special training course and obtain what is called a waiver that allows us to prescribe it in the emergency department. And not everyone has gone through that training. But generally speaking, in larger emergency departments, there are several physicians that might be on duty at any given time. And generally speaking, there might be someone, or should be hopefully someone, that can help us use patient get access to medications that are necessary. But that's the long answer to yes, you still need a waiver. It is not, but the restrictions for getting a waiver have come down actually. So it is easier to prescribe many of these addiction treatment medications, but you do need a special, essentially a special, I won't call it a license, but it's basically a license, if you will.
Okay, another one from our chat. Has PDMP shown greater value / utility in practice, especially during COVID?
I'm sorry, I missed the...
PDMP shown a greater value?
Yeah, I want to clarify can you clarify if whoever put that in, if you can clarify what you mean by PDMP, so I'm not confusing anything, that would be great. I think that's Tiffany Chan. I can see down there. I'm gonna put Tiffany Chan's question on hold until she can clarify, and then I'm gonna go down to the next one. How can people find, I can see them somewhat. How can people find help they need, especially families that are struggling for support and don't know return? That question, of course, is the $1 million question, COVID or no COVID. I think a lot of it is identifying that there's a problem and identifying that you need to get help. But the barriers to care, again, hopefully they will reduce as we have better access. And there are certainly online resources. Mental health care in general, there are online resources that the state of Michigan provides to help find a mental health provider that can help. Oftentimes, though, that's sort of, I guess, the first place to start. Treatment barriers, though, obviously include not only proximity, but there's financial barriers as well. And until we see some of that change over time, that's going to be a challenge. I don't have any simple to how people can find the help they need, than identifying the problem, starting with their primary care provider, using county level community mental health resources. And I think that's why this St. Clair County forum is so important, for example, but every county, of course, has its own resources. And those are the places that I think start. Okay, right. Thank you, Tiffany Chan, Prescription Drug Monitoring Program. So the Prescription Drug Monitoring Program has been, it's a plus minus. So, we are required by law to log on and identify how often people might have used or had prescriptions to narcotics in the last number of days, and make sure that we aren't over-prescribing them based on a supply need. That is, so somebody with, let's say, a broken bone, they shouldn't be going through 20 Vicodin in a day. So it's what's reasonable, and we want to still be able to treat pain reasonably. But the prescription drug monitoring system, it has helped a little bit, but I don't know that it is really completely the answer. I think one of the questions that came up early on when we began to have that requirement was whether physicians prescribing pain medications would drop off and leave people in pain when they needed pain medication. And I don't think the jury has completely returned on that one. There are probably still lots of people in pain who, because of prescription monitoring systems, do not have adequate access. I can tell you from the emergency department, we are using a lot of alternative treatments. So, whether it's alternative medications to treat pain, or whether it's alternative medications that, if you will, distract from pain. We're trying a lot of different things. We're looking for an answer, but whether or not prescription monitoring has really made a huge difference, I can't say. I can just tell you, fortunately, I am not a fan personally of the electronic medical record. I think it's a huge pain. That's just my personal opinion. But the electronic medical record has actually done something useful. It's integrated with the prescription drug monitoring program. So we can actually pull up very quickly now what a person's recent prescriptions were. And that part has been helpful. I want to make sure that I answered.
Yeah, I'll read you one from a little bit farther up the chat. Do you have any insight as to why fentanyl has become so accessible in the past few years? Is it similar to commonly prescribed opiates that you talked about earlier?
Yeah, so the increase of fentanyl, I think, has a lot to do with, of course, the supply chain that we talked about and the importation of illegal drugs. So fentanyl, of course, has, from a potency standpoint, just, the tiniest little whiff of fentanyl is so potent that you can frankly sneak it into the country or sneak it in from or move it around in very small, easy to hide quantities that are very potent. And then of course it becomes a question of cutting it correctly or cutting it so that it's not harmful. And that's really been the problem with specifically with fentanyl. It's become a go-to alternative because it can be created synthetically, because it can be easily hidden and transported because it's so potent, but also because it is so potent, people are using it and using it in a way that they are quickly overdosing. I mean, we talk about whether someone is opiate naive, that is whether or not they have any degree of tolerance. And if someone does not have any degree of tolerance and they use one of these synthetics, whether it's, we focus on fentanyl, but there are actually even narcotic synthetics beyond fentanyl that are even more potent. If anybody is using any of those and they don't know that it's been cut with fentanyl and it's that much more potent, their risk of basically apnea, not breathing anymore, goes up significantly. And of course, we've seen fentanyl overdoses that are so off the chart, if you will, that they require not just one dose of Narcan, 2 doses, but a Narcan drip. We can actually put someone on a continuous infusion of Narcan to overcome the amount of narcotic that's in their system. So there's no specific answer to why fentanyl overdoses in particular have increased in my mind, other than I think what we've all seen or what I've seen in the headlines and reported on, and that's that, drug seizures at the border are up, et cetera. And of course, there's probably also, homegrown supply as well, but certainly there's a huge importation issue as well.
Okay, another question from earlier. Is youth substance use up as well when you were citing those statistics from earlier?
Youth substance use. So that's an interesting twist. I think it depends. This is my personal answer first. So my personal answer first is that I think it depends on the community. It depends on the demographic of the youth in particular. But what we've reported on actually, and what we've seen when you look at youth substance abuse across the board is actually that it has been successfully decreased on a fairly consistent basis. Now, I don't know that we have new statistics related to COVID-19, but overall, new substance use among youth has actually been on a decrease. Now, it was on a more significant decrease, I should say, over the years like 2017, 2018, and then it sort of plateaued, and there may have been a little bit of a bump in 2019, but relative to the new circumstances, that is COVID, et cetera, I'm not sure what youth substance abuse has been particularly. I can tell you that in the emergency department, of course, we see mostly adults or older substance. So I don't have any direct experience with an increase in teen substance use, but I would say that generally teens turn to more accessible drugs, and they often turn to things like alcohol and marijuana. But the problem is the gateway phenomenon. So when we've talked about this relative to vaping, we've talked about this relative to alcohol, one thing leads to another. And once somebody decides or figures out that escapism is a good way to deal with life, and I'm using that in a very broad term because there's a lot of reasons people turn to substances. In teen cases, it's oftentimes experimentation, et cetera. But the point is, once a teen figures out that substance use fits their lifestyle for whatever reason, they tend to move from one drug to the next. And of course it increases. And so that's where the gateway phenomenon comes in. Now, in the past, the gateway phenomenon had been, for example, I injured myself and the doctor prescribed me an opiate. A lot of that has fortunately decreased, but there are other reasons that teens are turning to drugs. And so I still think that's a problem. I still think it needs to be addressed.
Yep, I have one more question here. Is there an increased risk of COVID transmission for those with opiate addiction?
Yes. So that is a really important question. So as we know, COVID is not a blood-borne disease like hepatitis, for example. It is a respiratory illness. But substance use in general tends to mean that people's barrier to social distancing, mask use, et cetera, drop. I mean, I'll just be quite frank. People who are intoxicated, people who are stoned, people who are high, and, so different substances change people's behaviors. So it increases your risk of COVID in as much as your care in social circumstances in avoiding communicable diseases will decrease. I don't know many intoxicated people that wash their hands regularly. I have yet to see a highly intoxicated person in the emergency department carefully wearing their mask. So, it's the obvious things, I think. So yes, it does, but not in a sense that it changes your immune system that we're aware of. I guess that would be the sort of the other medical side to it.
Sure. Okay, that brings us to the end of the questions that we've submitted. Do you have any closing thoughts to leave us with today before we go?
I think it's pretty much what I talked about before, and that's that we're in the middle of a global pandemic, yes, but that does not mean that the opioid epidemic, although it is not in the headlines, has gone anywhere. The statistics are very clear. The opioid epidemic remains a serious problem and a growing problem. And hopefully we can all keep, that is, people that are focused on it, keep their eye on the ball and continue to hammer away at the problem and continue to pay attention to the people who are in need, who need care out there, who are not able to get it because they're either unidentified or they have barriers to access. Until COVID is over, we just need to keep trying to help people who have opioid or any addiction problem. And then once we figure out the COVID thing or the COVID thing gets better, hopefully we can keep the good parts that we learned during COVID-19. Telemedicine, for example, and the prescription barriers to addiction recovery medications being lowered. Hopefully we can keep all of that and move forward and create a hybrid model that allows us to really use the best of both worlds. That would be my hope going forward with all of this. I apologize for all of the Zoom and technology issues, but hopefully this has been beneficial to someone out there.
Thank you so much, Dr. McGeorge, for your time today. It is so appreciated, and it was a wealth of information, and we truly thank you. We also want to thank all of you for logging into today's presentation.